yeah, there were many years before integrated care that I practiced, but yeah, had some of those leanings around maybe I should have been a psychiatrist or a therapist because the
Yeah.
biopsychosocial context stuff I think matters to me. And I guess I didn't really have a model or language for that till I started listening to you all and learning from you
Oh.
guys with your backgrounds and experience of, oh, that's a thing. It's integrated care. And here's how you actually do it. And I was hooked.
And here we are. I am so glad that you're both here today and so glad to be here. Hello, welcome to the Integrated Care Podcast from the Collaborative Family Healthcare Association. I am Grace Pratt, one of the co-hosts of our podcast, and I'm joined by just two others. We have a small team today, but it is always a joy to get to talk to any of our colleagues and have these conversations. But we will do some quick introductions and then roll right into our topic. So I'm Grace Pratt. I am the behavioral medicine faculty at Integra's Great Plains Family Medicine Residency Program in Oklahoma City, Oklahoma. I'm a licensed marriage and family therapist and have been working in this field in medicine for, guys, I was counting up. Earlier this week was my 12-year anniversary in this job. And then if you count the time before that I was in training working in medicine, we're getting on up there in the upper double digits of the teens.
Exactly how many years in the integrated care landscape?
In integrated care, 15
Wow.
years. I know, right? Because I started pretty much day one for my PhD program. I had just finished my master's in marriage and family therapy, had done, at the time, it was 500 hours of direct patient care in traditional therapy settings to complete that master's program, and then rolled right into my PhD. And they were like, okay, cool. Here's this tiny rural family medicine clinic in Snow Hill, North Carolina, in Greene County. And that's not the North Carolina accent because they have a whole different thing. That was my Texas coming out. But they said, here, go do integrated care. And I was like, what? I love insight and deep therapy work and emotional processing. And it was a little bit of whiplash. I think I've talked about that story before, but yeah, marks 15 years now. That was August of 2011 that I showed up there and started trying to figure out what the heck I was doing. And I guess I'm still always trying to figure it out. Yeah, thanks for that question, Monica, to take me back. So you just heard her voice, but we also have Monica Williams here.
Yeah, a little take back to nostalgia. Hi, everybody. Monica Williams, licensed clinical social worker by discipline, but lover of all things integrated care. I'm the clinical trainer and implementation coach at the AIM Center. And
How many years for you in
I
integrated
was
care?
just getting ready to be like, because, I hate to ask other people
I know
stuff
you
and
got to
then don't
answer if
answer
you
it
asked
yourself.
it.
20, geez, 23 years in the integrated care landscape. I hopped on over from early childhood background, and there
No, I
was
mean,
an
when you
easy
start working when you're
mix.
13, 14 years old, you can really
Oh,
pack all those years
boom.
in.
When you're young, you can do that.
Oh, I love it. We love having all of your years of experience and voice here on the podcast. And then rounding us out for today, like I said, we're a small team, but mighty. We have Jen Thomas.
All right. Hi, everybody. Jen Thomas, family medicine, addiction medicine physician in Illinois and co-medical director at CFHA. I guess I'm the baby of the group. I'm like year 7 clinically in integrated care. I learned of it in 2018, but really haven't done it in my day-to-day primary care work since, 2019 we launched. So yeah, I'm the newbie to
Oh,
our group of 3. But yeah, it's been fun. Gosh, AIM Center, where Monica is, they were my benefactor origin story of this is how you do collaborative care model. And we got to learn from them and be part of some research studies. So yeah, we go back, gosh, prior to the pandemic, feels like a before and after, right?
yeah,
In
no
a
kidding.
lot of ways. But
Yeah.
yeah, so good to
How
be here.
long? Because I feel like some of the work that we do and some of why I love working with you, Jen, every time we get to collaborate on something is that you were thinking in these ways much of the time, even before you were doing integration. You were already doing an holistic approach to caring for your patients. And clearly your heart beats with a biopsychosocial model that connects with us. How long have you been in practice?
Yeah, so I finished residency in 2010, and clinically I work for Morris Hospital. So I'm 16 years as a real doctor out of training. Yeah, there were many years before integrated care that I practiced, but yeah, had some of those leanings around maybe I should have been a psychiatrist or a therapist, because the biopsychosocial context stuff I think matters to me. And I guess I didn't really have a model or language for that till I started listening to you all and learning from you guys with your backgrounds and experience of, oh, that's a thing. It's integrated care. And here's how you actually do it. And I was hooked.
And here we are. I am so glad that you're both here today and so glad to be here. And I was looking back over our list of episodes, recent episodes, and I was thinking we've been hitting some really interesting high level things in terms of policy and organization and implementation. But it's been a while since we've had a truly clinical topic. The three-world view, all of them have to be in balance, right? And we've talked a lot of operational and financial, so I think it's time to reel our clinical back in a little bit. And so we were throwing out ideas, and we wanted to talk about ADHD, but we don't want to do that without Ashley here, because we for sure want to hear those, the dietary and nutrition components of that and involve her. And so we were talking about what else has been going on lately. And we started thinking about older adults. Now, you can listen back in January of 2020. Speaking of before and after times,
Talk about
holy
time,
cow,
right?
I know, like the time capsule of the before times. We did have an episode on geriatrics and primary care. Full disclosure, I did not re-listen to that before we recorded today, and I don't think either of my co-hosts did either. So TBD how much of ourselves we repeat versus how much we diverge into something different. I think I may have
How
been.
long ago was it? I don't
It
remember.
was
So maybe I will
January of
not.
2020. Do you think either of you would have been on that episode? I know.
January
Uh-huh.
2020. I was
Yeah.
a part of the podcast then, but I don't remember that one because I don't remember.
I don't know. Sometimes I
Wow.
listen back the next month and I'm like, wow, I said that. I totally forgot about that. So
Sometimes you're
January
super
2020 is like
smart.
a whole lifetime ago. Yeah. Anyway, we're going to do it again. And I think it really is a perennial topic when we're thinking about who we're caring for in primary care and across minor little news and notes section. And Naftali can drop in anything here in post if there's something else he wants to announce. But we have a special segment coming out that's going to be released as a different episode about doing integration in tertiary care settings or specialty care. So Jen, could you plug that just a tiny bit so
Yeah.
people know to
Oh,
look
yeah.
for it?
Yeah. I would be happy to. So, yes, I had the awesome opportunity to talk to some wonderful integrated care leaders. Just a few weeks ago, we recorded in July. Kim Smolderin is a psychologist out of Yale in the cardiovascular department and leads integrated care work there. Tony Mahold is in Minneapolis, integrated care health psychologist in a cardiovascular setting as well. And then Jonathan Deaches is in West Virginia doing a lot of work in bariatric medicine and weight loss medicine. And we had an awesome conversation pulling those three brains together. And this is really out of the brainchild of Tony and John, who kicked off a new work group with CFHA for folks doing integrated care and specialty. They had a session at the national conference in 25, which was great. It was Should We Gather? I loved that because like people know about the GATHER acronym, right? For primary care PCBH model. And they kind of went through, and they're still going through the letters in their monthly work groups, looking at, hey, okay, does a generalist approach work if I'm in an oncology setting? Does accessibility matter as much in oncology as primary care? So they've had a really neat, great year. They've done the work group now over a year, and they're going to have a lot of great conference sessions at St. Louis in 2026 too, to build on their work groups. Definitely recommend checking out that episode. They're wonderful interviewees, got great energy, and really cool to hear from their perspectives how they're making the integrated care rubber fence, like you say, Grace, right? Stretch things around models and approaches in their settings. So yeah, it's going to be a great episode. Definitely check it out.
I love that. We'll look for that. And I will plug that in. We also have, is there anything we can say about the conference that's coming up? I'm putting you on the spot.
Yeah, oh, absolutely. Big picture stuff. So, Naftali puts in the listserv a lot. Integrated care ain't the new kid on the block. It's great, but a lot of people have heard about it now. But where are we going as a community, right? We got to keep our eye on how does integrated care stay relevant? What are the big questions in healthcare? So we're going to be doing a lot of macro level conversations and bringing in that 3-world view with sessions around, okay, are we all at the table and are we all pulling in the same direction? Hopefully having more and more folks representing leadership, C-suite folks that drink the Kool-Aid and know about integrated care and love it and can be ambassadors for it back in their systems. So yeah, a lot of good stuff happening in St. Louis.
Love that. We hope to see everybody there.
Yeah.
Okay, so shifting gears a bit, let's talk about our topic for today about older adults and geriatric care in integrated care. So when we raised this a minute ago, Monica, you said you've been preparing some things that are coming up that has this fresh on your mind.
Yeah, definitely have been. At the AIM Center, we do a quarterly webinar series on all things collaborative care, but we always set the stage based on some population. And what has been coming up recently in preparation for that October one is around the geriatric population. Older adults. I'm always curious what words are going to offend individuals, right? I don't know. Am I now getting ready to be an older adult? I turned 50 this year. Am I now an older adult? I don't know. I say seasoned.
Girl,
Whatever you want to call, right? Like whatever you want to call the population that just has some different needs. And I think when we think about the geriatric, older adult, more seasoned, I don't know what other words, population, there just are some additional considerations that I don't think we always have at the forefront of our mind from a clinical standpoint. And so some of those things have been twirling in my mind, not just from a collaborative care standpoint, because yes, the original collaborative care research was with the older seasoned population, but even in my time doing PCBH and just integrated care in general, even I've done some specialty and all of that, like I remember some of the nuances of working with older adults, especially when it came to the cognitive decline that could sometimes exist and how some of those symptoms could very much mimic other behavioral health symptoms. And so teasing that out, what assessments are you using? What screenings are you using? Are you doing any type of cognitive screening? Right? Like just all of those pieces, and I even higher need for coordination of care with behavioral health and medical, as well as if you're fortunate enough to have other people on the care team that do a lot of care coordination and stuff like that for that population.
Yeah. I wonder what it looks like in your practice, Jen, because I think about who do we see in our clinic with our primary care clinic, and it is a lot of times a lot of older adults because they have insurance, they have a lot of times a lifetime of chronic illnesses that now are coming to a head, in addition to the things that Monica just mentioned that come into factors in terms of cognitive changes or changes to mobility and all of those activities of daily living, all those things that are important. So what does it look like for you in your practice? How much of your work would you say is with older adults?
Yeah, a fair amount. So my training background's family medicine, and we're very values driven of lifespan, right? We really take pride in the whole, you could see that same clinician throughout they could deliver you as an infant, see for your pediatric care, young adults, and so forth. And the fact that oftentimes, especially in smaller rural communities where I work, you get to treat the whole family system. So you treat mom, dad, kids, aunts, uncles, and their grandparents and their neighbors. So you really do get a neat sense of the lifespan of care. So yeah, in my personal practice, I have a fair chunk of geriatric patients, and your point, Monica, was spot on. Even more of a time for increased communication and team-based care, because there's a lot of overlap, right? Your elders oftentimes have chronic medical conditions where we're not the only medical shop they go to. Sometimes in younger years, people may only see a PCP or gynecologist, healthy young people sporadically. But as we age, sometimes we have more touch points with healthcare and have a cardiologist and a nephrologist. And we need hip placements. And now we go to ortho and physical therapy. Very much more opportunities to coordinate with the team, and unfortunately more opportunities to drop the ball in silo, where it's like, oh, we didn't know that cardiology started this med or stopped this med. It's an opportunity, but also probably more of a challenge to really get good team-based care, because patients might have more care needs and different care needs. You mentioned, Grace, like just cognitive decline. There's just so many things that change, in that era of life. Medically, sure, but functionally, right? Like sometimes folks are dealing with things around changes in vision or ability to drive and being more isolated, grief and loss of partners and friends. And so, yeah, there's a lot of layers of where integrated care can be really helpful when someone comes into primary care and, yeah, sees the doctor. But hey, by the way, we have a behaviorist, we have an integrated care approach. So not only can we talk to you about maybe a depression medication, but hey, we have care manager Melissa, who's great at helping with some of your sleep concerns. And hey, let's process the grief of your wife passing away a few months ago. So those kind of things I think come to mind for me.
My friend that is a geriatrician in my office, he likes to cite like a historical, there was a summit of all of the people that address the needs and health concerns and psychosocial needs of older adults. And he would give me, this is one of those things I've heard him say so many times that I've forgotten where the citation has come from. So like you keep saying that I'm rubber fences. That's not me, but I love that you associate it with me. Anyway, he said they put all their heads together, and part of their summit was like, how do we describe the process of aging, and what is a word that we can use to describe it? And the thing that they all came to a conclusion of is that a word that is prevalent is loss. Because if you live long enough, there's loss of the people around you, there's loss of identity, there's loss of mobility and functioning. And not to say, oh, it's just so sad and all of these things are so inevitable, but also it's something that people carry. And I think we also don't want to just be like, oh, yeah, that's what it means to get old. Everybody around you dies. Sorry. There's so much opportunity to connect and support, whether that's through normalizing, but also helping differentiate. Okay, here's maybe what is normal and expected, and here's maybe where we're getting into a territory where it's not, and we have some more opportunity for intervention. You rattled off so many things that we can provide support around and that lend themselves so well to integrated care. I wonder what else floats to mind for either of you as you're thinking of what are some opportunities. Obviously, each individual patient is different, and we know that there's more differences within our groups than between them. But what are some of the common themes that come up when we're working with older adults in integrated care?
Yeah, I think Jen did list off of a lot. Yes, we are patient-centered, right? So the person in front of you, but I do think it's important, especially if you have a large subset of a population of patients, to have some type of protocol or guidelines about what are the screenings you will do. You still want to have some measurement base, right? Whether you're doing PCBH, collaborative care, expert, and everything in between, a hodgepodge, whatever you're doing in integrated care, you do want to be able to have some type of measurement-based care that you're providing in some way, shape, or form. And so some protocols around what are we seeing in this population. So some of the things that Jen mentioned in reference to activities of daily living. So sometimes functioning is changing. Memory, as I mentioned, is going. So thinking about what the care ecosystem will be around that. But I think it's important to then have some type of protocol about here are the assessments or the screenings that we will utilize that then could let us know how they're doing. So yes, loss is inevitable in life, but everyone's going to be handling it differently. And I am a firm believer that some patients, many patients, if you ask them, they will tell you. But you have to ask. People aren't always just going around just offering the information up about how they're doing about certain things in their life that for us seems normal, but people are responding very differently. So I think some protocol of some type of here are some of the screenings or assessments that we want to ask this population of patients to get a peek into how they are dealing or coping with getting around and walking, with some of the physical pieces of it. I remember that was back when it was my first aha around UTIs and the imbalance that it causes and the difference that could happen for some with their emotional state because of a UTI, right?
Yeah.
So here's where that intersection becomes so very important, that you're in communication and that we're asking the right questions.
Yeah. Yeah. That brings to mind a memory of mine, Monica, from training residency. I was on internal medicine and the attending was like, let's talk about delirium, acute mental status change. I'll tell you about my mom. she never pulls the car into the driveway. And she did. And she hit the inside of the trash cans in the inner part of the garage. And sure enough, I knew she had a UTI. And I remember my young brain learner being like, UTI, that has nothing to do with that. That would be like burning in frequency. And he's like, no, in elders, sometimes they have acute mental status changes. And she was a bit confused and did something out of the ordinary. And her husband was like, in the 45 years we've been married, she never pulls the car into the garage. And she did. And that was an odd behavior. So that obviously stuck with me. And now I have seen that multiple times for elders, that there's mom's not right. Something's going on with her. So while we have the biopsychosocial, yes, like sure, we're not missing early dementia. Let's not miss medical things that are an easy fix. Let's get a UA, and lo and behold, there's a UTI. So yes, that's so true. So
it's such a point of why integrated care can become so important, is that we have all of these parallel tracks that we can address all a little bit at the same time. So, Jen, you're thinking to let's do that differential and rule out the easy medical stuff. Because of course, if it's just going to be a UTI, great, let's treat it and get better. And I think a lot of times our social support system, engaging them and involving them in the integration and like pulling in those family members and having interdisciplinary meetings and thinking about, is there a grief component here? And how do you differentiate between depression? One of my favorite articles that I make my learners read in their geriatrics curriculum is about a differential between depression, delirium, and dementia, because there can be so much overlap in those mood changes. And so figuring out like, what can this mean? And so much of, especially in the earlier presentations of dementia or of depression, is we have to wait and see. We have to try a treatment. And if treating the depression means it gets better, then we know it's maybe not dementia right now. Or these are for sure some signs of cognitive decline, but we don't know what the course is going to be, and we don't know how long it will take. And there's really not great medications around this. So what supports can we provide? And I think if we're talking about opportunities, so many times people are presenting in the hospital and they're like way down the road, and then the families are having trouble accepting and they can't name what's going on, and it's gotten progressed to such a bad place. But moving those conversations so much more forward when we're talking about people's values and what do they really want from their family, from their end of life, from their social support, way before it's actually the time, can be such a gift that we give them. But when do you do that in primary care? When do you do that as a PCP, when you're seeing them for all of the different things and you have these short things? And so having that opportunity to work together on it.
Yep. Yeah, absolutely. And what you said, Monica, too, around what's the protocol? What are our workflows? How do we screen? So what comes to my mind is the both and. So we all use a lot of PHQ-9 in primary care that we can use as a screening tool. Maybe there's universal protocol and a universal screening. Everybody 12 and older gets a PHQ-9 annually. And we can also use it as a tool like in collaborative care model or other approaches to monitor, right? Measurement-based treatment to target. Your score was a 20 last time, now it's a 15. We're moving in the right direction. There are equivalent things that we can have opportunities to do in primary care. So what jumps to my mind is things like the annual wellness visits. So Medicare has a whole push, and that's part of the culture of primary care, that folks that are Medicare beneficiaries get annual wellness visits. And that's a really nice opportunity to sit with patients and zoom in on a lot of the preventative stuff that sometimes we don't have time for, right? So if someone comes in for a series of acute visits, or they're doing a lot of follow-up for the diabetes or their heart disease, you may, in busy primary care, like, all right, when was the last time we had a conversation around colonoscopy or did a cognitive assessment? Shout out to those visits that when we first started doing those in my clinic, I know we were a little kind of grumbling at first, because, oh, it's a lot of paperwork, it's blah, blah, blah. But like anything that's new, the more familiar you get with the tools, the more efficient you can become. And it's rewarding to pick up on, hey, we detected this, breast
Early.
cancer early. Yeah.
Yeah.
We found it earlier. Oh, hey, we got this person's had a little memory something, and sure enough, they need to go see neurology because there's a dementia coming. In that annual wellness visit, we'll do like a Mini-Cog. Mini-Cog is a real quick,
I was thinking that same
minute,
thing.
right? It's fast.
Yeah.
It's primary care. You gotta be quick. We don't have time for 30-minute assessments. So it's 3-word recall and a clock drawing test, and it tells you a lot. So we can use that there for like the preventative visit, and we can pull it out when there's concerns, because you get that question a lot in primary care. If I have memory concerns, even people that are young, it's like, is this ADHD, right? I have poor memory. Does that mean my attention's bad? and the elders of dad's not remembering things, he's forgetting things. Is this dementia? You get that question a ton in primary care. Mini-Cog is a great point of care tool for screening. The MMSE, the mini mental status exam. I remember learning that as a med student. That's a goodie, oldie but goodie, that it doesn't take very long. And then you have a score and you can have an informed conversation with patient and family around, hey, the score's a little abnormal. Let's look into this. Maybe we get you set up with a neurologist for further eval. Or hey, that you scored normal. It doesn't mean you don't have memory concerns, but we got some data today. Let's repeat it in 3 months when you come back for your diabetes med refill, and let's make sure there's no decline in those screening scores. So yeah, that's important. That's bread and butter. It's not real glitzy sexy, but that's the important part of prevention, I think, is like be diligent now to kind of catch things early.
Yeah, 1,000% agree. We definitely use the Mini-Cog and train, like all of the clinicians were trained on that, which kind of between you saying that, Jen, and hearing Grace talk about curriculum, right? Just thinking clinically, for those of you who are clinical supervisors and clinical directors, like the importance of making sure your team is equipped. And so getting training in some of these things is really helpful. So yes, most behavioral health clinicians have gone to some school, regardless of the discipline, right? And you've been trained on some things, but a school cannot possibly teach you every single thing. And nobody is pulling out the DSM and making you go page by page through the DSM, right? And so having the opportunity to get training in some of these things like the Mini-Cog, what is it, how to do it, we definitely had in our protocols. We did it on certain patients at a certain age and point, but also would do it if a need arise. But we were able to definitely catch some patients with that kind of early intervention, like Jen was talking about, because we could start to see, wait, okay, there's a decline from last year by 10 points or however many points. And it was just like similar to how when we talk about the PHQ-9, that it doesn't necessarily mean somebody has major depressive disorder, but it's like hey, something's going on right here. We need to look into this. Same way we do with the blood pressure. It's like, hey, something's going on. We need to look at this. And so it definitely were some patients who it was brought to our attention, like, okay, we need to do a little bit more evaluation, a little bit more communication with the family. What really sparked me as one of the things that we don't always think about with pediatrics, we instantly think about including the caregiver, like whoever their guardian is, and the school. And like we think about this, it's instant, like it's a kid, we already know. We don't always think about that with adults. And I'm going to say even more the geriatric population, right? I think that those conversations, who are their social supports, who are like, when my mother-in-law or my mom, something is going on, like there's a person that some of the providers will call instantly while they're in the session just to say, here's what we talked about today and here's where things are. That does take more time from the provider or from the nurse or MA, whoever's in charge of doing that. But then there's other providers where I hear nothing. And it's like, all right, but thinking about those things from a workflow standpoint, like Jen was talking about, what does that look like? What does it look like to engage that person's supports? When something is a little bit amiss, who are we going to talk to other than the person in front of us? Are we going to ask them who else they'd like to be involved in their care? We really should be asking every patient that, if you ask me, but that's another story for another day. But particularly, we don't think twice about it for pediatric patients. Everyone else, it's kind of like this side optional piece. But I would say the times in which I did not have someone to contact for my geriatric patients where something was going on, those were very hard visits, very hard to get any traction going, to know this person is going to really have the help that they need outside of the medical office. Yes, if something was going on, my provider might have home health go in. Home health isn't forever unless you have the most amazing insurance known to man. Like home health is not forever. And what does it look like to actually have some sustainable supports there for this population?
Yeah, and PCPs just so appreciate that, because I can think back, we were talking before times and after times. Before I practiced with integrated care, it would be next to impossible to get that collateral information. If they didn't show up with a caregiver or a family member, you're booked every 15 minutes, 10 minutes, you do your thing. Ooh, I would love to know, what does home look like? Are they having difficulty with making their food or managing their checkbook and stuff? Some of those executive functioning. Where does that fall? It falls through the cracks unless you got a super powerful nurse but again, they're beyond book two. They're doing the job of three people. That's where I think it's such a game changer to have additional teammates, because you have someone designated like a BHC or a BHCM that's like, hey, when you see Monica next week for your session, bring your wife or bring your daughter-in-law. That's so cool. And it really is powerful to help us get better whole person care when it's like, oh, great, we know primary care is overwhelmed. We know clinical nursing staff has so much to do, a never ending inbox. But hey, with other teammates, we don't have to work harder. We work smarter because we
Yeah.
have integration. Dang it. It makes sense.
And I think the more ambiguity there is in terms of what's happening or what is the course of it or what's even possible to intervene on versus what is inevitable, and holding that grief and loss, the more ambiguity there is, the more our team-based care shines, because it's being able to no one person has to carry all of that. We get to share it. We get to all work to the top of what we can do to provide support. And we all have something a little bit different to offer and to share with that patient and with that family. And it's just such a relief to me, even as a clinician, to know that it's not just on me, but it's all of us. And I think that's especially true when we're talking about our aging patients and talking about a lot of the ambiguity that does come, and finding ways to hold that tension of, we're going to intervene around what we can, but there's also a lot of this that has to be grieved and can't be fixed, and finding where that line is and helping patients and families come to accept that is really, there's the added bonus too of, it's not just their doctor telling it them, it's us reinforcing it too. And it's not just us, it's also their physician, and it's also like all the team being on the same page, I think helps a lot too. Yeah. I know that we have been aiming to have a little bit shorter episodes, and I know that we have an incredible bonus episode coming out that we hope people will invest some time listening into. But before we wrap up, I wonder what takeaways, what clinical pearls, like if you had one of our brand new clinicians sitting right in front of you, what would your encouragement to them be as they're maybe staring down a list of patients one afternoon that they need to see that are all from this population?
I think I would
One,
say,
always one.
one. Take a breath, right? And don't get overwhelmed, because, like they say, kids aren't little adults. Geriatrics, they're individuals too. And if you take the time and be a good listener as much as you are a clinician that likes, hey, here's your diagnosis, here's your meds, it's really rewarding to connect with patients in that season of life, to hear from them and the stuff they've learned. And it just makes it a really powerful part of the caring for the life spectrum to work with geriatrics, even if it's more challenging and they have more longer problem lists and more refills. Don't get overwhelmed. You don't have to do this by yourself. You've got a team, hopefully, with integrated care to lighten the load.
Yeah, I would ditto everything that Jen said and just encourage them in the spirit of figuring out key kind of diagnosis differentials to use a geriatric depression scale or something of that nature. So just to tease some of these things out as they continue working with the entire support system for that patient.
Yep. Awesome. I think those are both great encouragements. And I hope that there was something in here that feels like a bit of encouragement or a bit of direction as you're thinking about working with your older adult populations in integrated care. We thank you so much for joining and listening with us this month. We are looking forward to all of the good things that are coming. We are looking forward to talking to you again really soon. And so thank you, Monica and Jen. Thank you to our listeners, and we'll talk to you again next month.